Professor William C. Epco's teaching hospital. He's in the person of Dr. Nicholas Kumi. With a round of applause, I will welcome.
All right. Good morning.
Good morning.
As Shirayi said, my name is Nicholas Kumi. A lot of my colleagues call me Dr. Kumi, but I prefer to be called Nick, so you can call me Nick. Right. I'm a specialist clinical pharmacist at the Teaching Hospital, ICU. I'm actually honored to be here, and thank you very much for inviting me, Mrs. Yossi and team. Thank you very much. So I wouldn't waste much time. We'll just start with the presentation. Our outline for today is look at what vasopressors are, how they work. We'll use a case study to talk about a few issues that we face in the ICU, when to start them, how to choose them, when we choose them, what goals do we look at when you start administering them, how you actually administer them, and issues concerning using vasopressors, running them through a peripheral line or a central line. How do we add on vasopressors, and when do you actually add on vasopressors? And we'll look at some new agents that are not like vasopressors, but they work like vasopressors, okay? Right, and how to actually wean a patient off a vasopressor, right? So, shall we begin? Our objectives is, well, most things in the ICU, we can't do away with pharmacology, right? So, we'll look at some receptor physiology in cardiovascular pharmacology and differentiate between what a vasopressor is and what an inotrope is, and discuss certain nursing care issues when patients receive vasopressors. What do we actually do? So vasopressors, just like the word vaso and pressor, they are just drugs that increase systemic vascular resistance, and consequently, it is increase your blood pressures, okay? And we know a formula for BP, which is cardiac output times total peripheral resistance. So when we increase the total peripheral resistance, would increase our blood pressures, isn't it? Please, I would like the presentation to be quite interactive, okay? So vasopressors simply improve organ perfusion, right? When we increase our blood pressures, we increase the mean arterial pressures, and that would increase tissue perfusion. Basically, that's how they work. And they will work through mediating certain adrenergic receptors. I don't need to go over cardiovascular pharmacology, do I? Right. But if you need to ask any question, please note it down. I would like to go back and visit that. So they mediate cardiovascular actions through alpha 1, beta 1, beta 2, right? These are adrenergic receptors. Okay. We have some that would mediate dopaminergic receptors. We have some that would also mediate vasopressin receptors. We have two, that's V1 and V2, and then angiotensin 2 receptors, okay? And typically angiotensin would act on angiotensin 2 receptor, right? So let's look at what would happen if an agonist or a vasopressor, which has agonistic activity, sits on one of these receptors. So typically for an alpha-1 adrenergic receptor, typically it would cause vasoconstriction. Beta-1 would increase myocardial contractility, that would increase stroke volume, that would increase cardiac output, right? Beta-2 mediates bronchodilation. We also have some beta-2 receptors on blood vessels that would mediate vasodilation. Then we have dopaminergic receptors. Dopaminergic receptors are found in the kidney, in the splanchnic area. You can find them in the heart, some cerebral vascular beds. So what we would focus with dopamine is on the kidney and generally on blood vessels, okay? Right, and then vasopressin, which is basically on blood vessels. For dopamine, the actions on each of these areas is a little bit different. So dopaminergic receptors in the kidney will typically cause vasodilation, If it acts on the heart, it's acting on beta 1 receptors. That would cause an increase in myocardial contractions and stroke volume and the like. But peripherally, when it acts on alpha 1, it would rather cause vasoconstriction. Okay. So I've already mentioned how they work, but we basically group vasopressors into two main buckets. So we call a group catechol amine vasopressors, to help you remember. Catechol amine vasopressors and non-catechol amine vasopressors. Okay. The catechol amine vasopressors are catechol amines, so they are more of like adrenergic substances that would ideally activate alpha 1, beta 2, and the like. Right. Then the non-catechol amine group are not working on adrenergic receptors, so they would mediate vasopressin receptors V1 and AT2 angiotensin 2 receptors. Please, are you all following? All right. So examples of the catecholamine vasopressors would be noradrenaline, adrenaline, phenylephrine, dopamine. These are catecholamine vasopressors, right? And then the non-catecholamine vasopressors would have vasopressin in itself, and angiotensin 2. So why are they catecholamines? They all come from one amino acid, tyrosine, and they all have a basic structure, which is the catechol structure, right? So the catecholamine, no. So this is catechol, the catechol group, and then the side chain is the ethylamine. That's why we call them catecholamines. So how do we get the rest, like norepinephrine, epinephrine? So it's just substitutions on the side chain. So the difference between noradrenaline and adrenaline is just a methyl group. Let's just look here. This is noradrenaline. It's the same thing. We just added SCA3 to it to give us adrenaline. Okay. Right. Now let's go into details and see how different each of the vasopressors are. We'll talk about a few of the inotropes in terms of their receptor physiology. So typically, if I take noradrenaline, let's use like a speedometer or a spectrum, a scale. On our right side, we are going to think about alpha 1 effects, right? On our left side, we'd think about beta 1 effects. Please, is that okay? Right. So moving from our right side to the left, we are changing the way the drug or the vasopressor will act on the receptor. So if I move towards the beta 1, I'm having more beta 1 effects. Okay, right. So a typical agent that would have pure alpha 1 effect is phenylephrine. Phenylephrine is devoid of any beta effect, so it's a pure alpha agonist. So on our right side, we'll start with phenylephrine, which is a pure alpha agonist. As we move towards the beta side, and we start seeing drugs like noradrenaline. Noradrenaline works on alpha receptors, but it has slight beta 1 effect. Okay, as we move a little bit closer, now we are in between having alpha and beta 1 effects. Then we have something like adrenaline. Please, do you prefer adrenaline or epinephrine, noradrenaline or norepinephrine? All right. So we have epinephrine, which has beta 1 effect, right, at almost all infusion ranges. Then it will tend to now have some alpha effect, okay? So as we get closer to the beta 1, then we have now an agent that has purely beta 1 effects, like dobutamine, which is an inotrope. Remember I said alpha 1 causes vasoconstriction, beta 1 causes increase in myocardial contractions and stroke volume, right? So if I'm veering towards beta 1 effect, then I have a pure beta 1 effect. A typical example is dobutamine. Dobutamine has beta 1 effect, it has beta 2 effect, it doesn't really have alpha effect. The beta 2 is more than the alpha effect, okay? Anyway, I said beta 2 causes vasodilation, isn't it? All right. And other agents like isoproterenol. Isoproterenol also has beta 1 effects, devoid of alpha effects, has some vasodilatory properties too. And vasopressin, like I said, is a non-catecholamine vasopressor, so simply works on vasopressin receptors. Please, are we all okay? All right. So let's take a look at this. Now, I said a vasopressor is a little bit different from an inotrope, but we have agents that have vasopressive effects and inotropic effects. So they are not truly pure vasopressors, and they are not truly pure inotropes. They just have the two. So a vasopressor, a conotrope simply would increase heart rate. And then the inotrope, myocardial contractions. So in between all three, you see adrenaline and dopamine. Because adrenaline, like I said, has beta-1 effect, which will give us the inotropy and gonotropy, right? And alpha-1 effect, which will be the vasopressor effects, right? Then phenylephrine and vasopressin, which are purely alpha-1 agonists, so just have vasopressor effects. Then dobutamine, which has purely beta-1 and beta-2 effects, so has more inotropy. Okay. Then isoproterenol, like I said, has a little bit of beta-1 effect. Beta-1 can increase your heart rate, so that will cause gonotropy. This agent here is, please, how many of us use milrinone in our facilities? None. Okay, so we have some of the agents that are not pressors. They are inotropes, but they are dilators, okay? So we call them inodilators. So milrinone is a typical one. Dobutamine in itself is an inodilator because it dilates beta-2 vessels that have beta-2 receptors. So it's an inodilator. It doesn't have vasopressive effects. Please, are you all following? All right. Now, why do we need to know this cardiovascular pharmacology? All we need is how vasopressors work. Like I said, they are going to increase tissue perfusion by increasing your mean arterial pressures. So they can either affect the output or the total peripheral resistance. And like I said, vasopressors would affect systemic vascular resistance or the total peripheral resistance, right? So what you want to do is increase oxygen delivery, tissue perfusion, by increasing blood pressure, which would be a function of the cardiac output and the systemic vascular resistance. Now, let's know that the cardiac output and the systemic vascular resistance have things that actually would affect it. A typical example is cardiac output will be affected by heart rate. Why? Cardiac output is equal to heart rate by stroke volume. So that's what you have here. So if I increase this, I increase the amount of time the heart pumps blood out per time, right? And this would be the volume. Now, what would affect volume will be your preload, the amount of venous return, the amount that's coming in. And most importantly, afterload, which I always describe as the force with which the left ventricle would have to overcome to try and pump blood out, right? So let's remember this. It will keep repeating itself throughout the presentation. So these agents are used for various reasons. Our lady here mentioned a few: septic shock, cardiogenic shock, different forms of shock. You can use any of these agents, but which do you choose and when do you choose what? Okay, that's what I want us to take through. So we would use a typical case study to go through how you choose an agent and how you add on and how you titrate it, and then certain nursing care issues that would arise. Please, are we all okay? So kindly take out your phones and scan this QR code for me. I think there is already a network in there. Washe. I've given you a heads up. What you're going to do is read a case study. There will be a number of questions that will be popping up on your phone, okay? Please answer them. Try and answer them as you go along. So I've given you a heads up on the first question that is coming. So let's look at the case study. So we have Mrs. Araba Forsen. She is 67 years old with a history of hypertension and rheumatoid arthritis, who presented to the ER with dysuria and fever. She weighs 50 kg. Findings upon her initial evaluation reveals leukocytosis, and she looks like she has a UTI, a urinalysis that's Roy Sonfa infection, so she has a UTI. She's treated with antibiotics, and she's febrile, she's tachycardic, febrile 39 degrees centigrade, tachycardic 120 to 130. A little bit, I don't know if you call that normotensive, that they said she's normotensive. BPs are 111 on 42. So upon admission to the ER, She's fine. Her SpO2 is 98 on room air. She's borderline tachypneic. That's 20 cycles per minute. After her antibiotic administration, she diffuses, meaning her temperature sort of settle. But her blood pressure gradually drops to 89 on 4:1 with a mean arterial pressure of 58. And as a result, she's given 3 liters of crystalloid, which transiently improved her blood pressures. But about an hour later, it reduces to 88 on 32 with a mean arterial pressure of 51. Saturations drop again to 90. And then she's placed on 2 liters of supplemental oxygen. Now, this is a typical case. It looks very simple, but someone with just a UTI and all of a sudden BPs are dropping, saturations are also dropping. How would we ideally have managed this patient? So let's go to the first question. What ideally would be your best course of action for Mrs. Forsen? So now I'll need you to answer the question. Okay. 88. Particular presentation. Now, one thing antibiotics do, depending on their mechanism of action, is to lyse bacteria. Okay, and when they do that, they release a lot of cytokines, inflammatory mediators, which are vasodilatory in nature. They release interleukins, nitric oxide, and the likes. They are all vasodilators. So what this will do is that just trigger an immune response, an inflammatory response, and that can drop the systemic vascular resistance and drop the blood pressures. Okay, right. Now, one typical thing about such drops in systemic vascular resistance is you can actually see it in the BP. Now, remember that she has a history of chronic hypertension, but the BP that was recorded was 111 on 42. What does that tell you? Probably 111 on 42 is not her baseline, because they are saying she's normotensive, but she's actually hypertensive, and that wouldn't be a baseline. So a typical patient like this, 111 on 42, shouldn't be an ideal blood pressure for her. Secondly, this disparity between the systolic and diastolic pressures, which is a wide pulse pressure, is very significant in patients who are characteristic in patients who have, say, a reduced systemic vascular resistance and typically septic shock. Okay, so what you'd see is that their cardiac output is still functional, it's still there, but their afterload, the systemic vascular resistance, reduces. So what you'd see is a disparity, just a wide pulse pressure. Right. So mean arterial pressure is now 89 on 41, and then dropped again to 88 on 32. Okay. So what would ideally do is, patient with the, if you follow protocol, you would realize that for septic shock, because there is vasodilation, there is a little bit of capillary leak, so patients normally will leak fluids. Okay, so what we'll do first is to sort of administer fluids. Okay, so we've administered fluids, but a BP dropped again. Why is it still dropping? Ideally, if you administer fluid and we do like a passive leg raise and all that, output should increase, perfusion should increase, BP should increase. That's what we should expect. But she's been given about 3 liters. She weighs 50 kg. So she was actually given like 60 ml per kg. That's a lot of fluids. Ideally, she should respond to this fluid, isn't it? So if she's not responding, it means that we need to go ahead and do something else, which is what? Give a vasopressor. Right, so it was correct. All right, so typically, when we use vasopressors, when you see signs of shock, and what are the signs of shock? Systolic BP less than 90 or greater than 40, decrease from a baseline, especially when the patient is hypertensive, altered mental status, capillary flow time, which is delayed, tachycardia, decreased urine output. I believe we all already know this, right? So when would we choose a vasopressor? We've chosen the vasopressor, but we should know that choosing the vasopressor, we need to think about the patient's physiology too, right? We said septic shock, you would choose a vasopressor. But which of the vasopressors? One is saying we should choose noradrenaline, but that begs into question. We said noradrenaline has alpha effects that can cause vasoconstriction and increase the mean arterial pressures, right? Okay. Now, what we should know is that in as much as we want to increase the systemic vascular resistance, there are certain situations where we wouldn't want to increase systemic vascular resistance because that would increase afterload. And I said if you increase the afterload, it will make it a little bit difficult for your left ventricle to pump blood out of the heart. So a typical example is in a patient with cardiogenic shock, right? How about anaphylactic shock? Someone has a bee sting, a bite, goes into anaphylaxis, has bronchoconstriction, angioedema, and the like. You wouldn't want to really choose noradrenaline. Just think about it. Why do we use adrenaline in these situations? Because adrenaline has more beta 1 and beta 2 effects. Then a pure drop in systemic vascular resistance. Yes, noradrenaline can increase your systemic vascular resistance. But if that is all I want, I'll probably want to choose an agent that would just... Oh, I think some of us have answered it. Hey, already ahead of time. Thank you. That was okay. Oh, okay. Sorry. So, the attending physician prescribes noradrenaline to run at 0.1 micrograms per kilogram per minute. Now, how would you prepare noradrenaline for continuous infusion? How would you run it? So we have, if you can all follow, dilute 1 ampoule of 4 milligrams of noradrenaline. Okay. Should we give it like about 5 seconds and see what the turnout is? We're still answering. But the majority is dilute 1 ampoule of 4 milligram noradrenaline, still majority, by titrating 50 ml in saline, and then perfuse it at the said rate. All right. So we've talked about noradrenaline. Noradrenaline mostly comes as 4 in 2 ml, 8 in 2 ml. We have even 32 milligrams ampoules. Comes in different strengths, right? And then normally the dilutions are to do it in a volume of 250, 500, 1 liter. Just calculate your rate in mL per hour, mL per minute. Then you run it. If you want to use a perfuser, you run it. If you want to use the infusion pump, you run it. Now, the issue about noradrenaline is, I don't know how many of us have actually taken a close look at our noradrenaline in Ghana. We have about 3 different sorts of noradrenaline. Please, are we all aware? Okay, which are noradrenaline bitartrate, noradrenaline tartrate, and noradrenaline acid tartrate. The acid tartrate just a few years ago started coming into the system. Now, the tartrate, when you write prescriptions for noradrenaline, you write them in their base forms. Base forms meaning if I write noradrenaline bitartrate, what I want and what I'm going to use, the API, is actually just noradrenaline. Now, the salt forms complicate the issue. I'll explain it. Now, noradrenaline bitartrate, if you have 8 milligrams of noradrenaline bitartrate in a 4 ml ampoule, okay, it's actually not 8 milligrams of noradrenaline. It's actually 4 milligrams of noradrenaline. If you have 4 milligrams of noradrenaline in an ampoule, please cross-check. It is not 4 milligrams of noradrenaline in, say, 2 ml. It is 2 milligrams of noradrenaline in 2 ml. So this is a very common noradrenaline that is in the market, this particular one. So let me just zoom in so that we see. So let's look at it closely. It says 2 ml, that's the volume, right? Okay. Each ml contains noradrenaline bitartrate 2 milligrams. So each ml, now the volume is 2 ml. So that's 4 milligrams of noradrenaline bitartrate, right? Now let's look at this. Equivalent to noradrenaline 1 milligram. They've done it, but they've actually told you what it contains, so we should also know. That's why I said prescriptions are written. If a physician prescribes noradrenaline, he doesn't write noradrenaline bitartrate or noradrenaline acid tartrate or whatever. He just writes noradrenaline. So all the doses that are written is for just the pure noradrenaline. When you get to the ampoule and you're doing your reconstitution, you should know what concentration you are getting. Because if you don't do that, and you do your calculation and you want to start as a set rate, people say it's the same thing, but it's not the same thing. What you do is that if I say you should run 0.1 mics per kg per minute, you will not be running at 0.1 mics per kg, you run at a lower dose. Yes, you run at a lower dose, which means it will take you some time to titrate and titrate and titrate before you get to where you want to get to. Please, are we all following? Right. So the acid tartrate is quite simple. The acid tartrate is like the US version of the bitartrate. So no, the UK version. So in UK they say acid tartrate. In US they say bitartrate. So it's the same thing. So acid tartrate and bitartrate and tartrate are all the same thing. What you should know is whatever amount that is stated is actually half of what it contains. Please, are we all okay? So what I mean is that if the ampoule is saying it contains 8 milligrams of noradrenaline in 4 mL, still cross-check. It is actually 4 milligrams in the same volume in 4 mL. Please, are we all okay? So if you are reconstituting and then you have the 8 milligram ampoule in 50 mL, you've not put 8 milligrams in 50 mL. You've put 4 milligrams in a 50 mL. The other thing is for all vasopressors and inotropes, please remember, preferably dilute them, do your reconstitution in dextrose-containing fluids. Dextrose-containing fluids. Simply, the dextrose in there reduces the oxidation of the vasopressor. So it sort of maintains the potency of the vasopressor because you might probably be running it for some time, isn't it? You know, Celine? Yes. Yes. Her blood pressure has improved. So we started our NORAD. Blood pressure improves to 97 on 43, MAP of 61. She feels better, more alert. What's your next course? What are you going to do? So you've started your noradrenaline, you've prepared it, you are starting it, things are improving. But what do you do? This is a question showing. Interesting. It seems there are 3. Okay, it's changed now. I think the highest is to set MAP goal of 65, titrate noradrenaline to effect with continuous hemodynamic assessment. Okay. Let's see what will be the correct answer. Is to set the MAP goal. I think we all agree because 82% of you chose that answer. So, what's this about setting an MAP goal of 65? Actually, there was a trial that was done, and they realized that which is a 65 trial, which realized that patients with a MAP goal, septic shock, MAP goal of 65, actually did better. Okay. Now, in this same trial, there were 2 groups of people. They set, for one group, they set using a goal of 60 to 65, another group more than 65, 10 millimeters mercury difference, so above 65, that's like 75, right? And then they compared the 2. They realized that those with the 60 and 65, there was no change in mortality, all of them did well. But those with 60 to 65, what happened was that they were able to achieve their targets very quickly. Obviously, 65 is lower than 75. But also the duration of vasopressor use was also shortened. Please, are you all following? Okay. So based on this, they decided to say that, okay, then let's use 65 as our MAP goal. And we know that the MAP is what we need for tissue perfusion, like at tissue level. That's what determines tissue perfusion. Okay. Now, in this same trial, there was another group of patients that actually they had chronic hypertension. And they realized that for these patients, if we set a lower target, we call that permissive hypotension, a lower target, like 60, between 60 and 65, not actually above 65. This patient did better than using a higher target. Why? Because they have chronic hypertension. Okay. SSC, Surviving Sepsis Guidelines, actually says a target of above 65. But what I want us to know is, although we know that we are titrating the target, MAP target of above 65, you're not just using the MAP, just watching the MAP. There are other things that you have to look out for. Why do you want the tissues to be perfused? Because they are hypoperfused. So what should you see? A typical example. The kidneys are hypoperfused, the person is not producing urine. If you achieve an MAP target of 65, what are you supposed to see? Some urine output. It says that the urine is a bit, or I don't know some style. When the kidneys are actually hypoperfused and you start perfusing them, they take quite some time before they start producing urine. So what other things can you look out for? Mental status. Realize that she had a 61, MAP of 61. She's awake, fully alert. Mental status, okay. What other things? Serum lactate. Lactate is a marker for anaerobic respiration, blah, blah, blah. So if you're perfusing your tissues properly, serum lactate should what? Should drop. These are some of the things that you should look out for. But at the best side, maybe you will not be interested in what? Labs, isn't it? Or we are interested in labs. Okay. So what you would also use is something like skin perfusion. So if the person is in shock, cold, clammy skin, isn't it? So it should be warm, right? Okay. Kidneys, you can look at kidney function and look at the serum creatinine. So these are more like dynamic measures for monitoring the patient. So it's not just about the figure, the MAP figure. Look at the patient. Please, are you all okay? All right. Okay. So now we are at 61, the patient is doing better, but we are titrating to see all those things that we mentioned. Now, how would you titrate the noradrenaline? I mean, how would you understand a titrate? Increase the noradrenaline. If you run it in an ABG to tell you that serum lactate is up, let's please take note of that. Lactate in itself is not really bad. It's more of like a marker. It should tell you what is happening. Okay, so let's focus on the trend of the lactate more than like the figure actually increasing, because there are a lot of reasons why serum lactate can actually go up. Running adrenaline infusion can cause lactic acidosis, can increase the serum lactate, because it actually causes glycolysis and then lactic acid production. So you can see that if you're running noradrenaline as an infusion. Please, are we all okay? Saturations drop to 80, respiratory rate 40, non-invasive positive ventilation is started. She's failed that one, so we think we should intubate her. The physician thinks we should intubate her. Her heart rate is 140, BP is 90 on 60, MAP on 70. So what the case studies are trying to do is to mimic when we use vasopressors in a typical, on a typical day. So now what you're going to do is sort of intubate this patient. Okay. Now the BPs are a little bit down. MAP is looking fine, but you realize that she's gotten worse. So now we think she has to be intubated, but the systemic vascular resistance has dropped. We want to intubate her. What should we do? Let's go ahead. So the options are: consider push dose vasopressor, administer crystalloids, carefully choose medications, continue her vasopressor infusion. Remember, she's on a vasopressor, she's on NOAD. Okay. So let's see what happens. Now, for RSI, rapid sequence intubation. Normally, for patients who you need to do a rapid sequence intubation, normally their sympathetic system is on the high, heart rate somewhere. Okay. But what happens is that when you intubate a patient, it numbs the sympathetic system. Even in fact, the medications that you'd even use would also do the same thing. So if I'm going to intubate this patient, then I should expect that 90 on 60 MAP of 70 will still drop. So one, either I do something to counteract that, or carefully choose my medications that I'm going to use for the RSI. One of the medications that will drop the BP is propofol. If you joke, it will crash your BPs. Okay. So that's one. The other thing is, when we do the RSI, intubate the patient, put on positive pressure ventilation, positive pressure in the ventilation in itself can drop blood pressures. How? It drops the preload. If you drop the preload, amount going in drops, cardiac output drops. BP is equal to cardiac output times total peripheral resistance. BPs will drop. Right. So what we do? So please, do you have any anesthetists around? So we realize that most often what they will do is that if you're about to intubate someone, they will sort of say that let's administer fluid. Give this fluid, right? And you would have to prepare certain drugs on standby, isn't it? We call them push dose vasopressors. So either you prepare like phenylephrine as a push dose, or epinephrine as a push dose, or ephedrine as a push dose, atropine, because you never know, maybe the patient will code, isn't it? Yeah. She's giving ketamine and rocuronium. We've intubated her. BPs are 90 on 60, but now decreased to 50 on 30. Let me just tell you something. This is very weird because, like I said, we need to choose our drugs very carefully. Ketamine doesn't normally decrease our BPs. It causes a catecholamine surge. So if you realize patients who are in septic shock, most of the intensivists would normally use ketamine to intubate them. They will not use propofol. Okay. 50 on 30, heart rate is 55. What should we do? We are running continuous NOAD infusion. Should we decrease it because we are going to use ketamine? Should we increase the rate? Or should we consider using push dose vasopressors? %. Let's take the 100%. It's actually considering push dose vasopressors. Okay. So what do push dose vasopressors do? Like I said, when you have a transient, when do we use them? When you have a transient drop in BP, or when someone is almost about code, not really coding, but the BPs have dropped suddenly like 45 on 25. You're not now going to prepare noradrenaline infusion and then start running it at 0.1. No, you need a push dose vasopressor. Now, what you need to know about the push dose vasopressor is the dilution, how you administer them. Please, how many of us have pre-mixed syringes of like epi or phenylephrine in our facilities? No one. Do we have some? No. You also have some. But what I would advise is take particular note of the dilution. So a cold dose epinephrine, please, who can tell us how to prepare a cold dose of epinephrine? Like if you're running a code, CPR, right, and you're administering adrenaline, how do you do it? In fact, like them, what do you do? Anyone? One in 10,000. Please, what does 1 in 10,000 mean? 1 milligram in 10 mils. Do we actually do that? So the code dose of epinephrine is 1 in 10,000. Okay? Outside, they have pre-filled syringes of 1 in 10,000 dilution. So that's what they use. But here, we don't have that. So our adrenaline normally will come as 1 milligram per 1 mil, which you need to dilute to 10 mils to give us 1 in 10,000. Now, for a push dose vasopressor in this situation, you just take that's 1 mil of the 1 in 10,000 that you prepared, dilute it further to 10 mils. Never use the 1 in 10,000 and say I'm pushing half. Disaster. Recipe for disaster. You don't do that. You see, what you want to do is not just, you don't want to push the BPs up. You just want to sort of take it somewhere that you can actually manage not take it to normal. Okay, that's not what you're going to do. So you need to take note of that. And phenylephrine can also be used because it's a pure alpha agonist, increase systemic vascular resistance and also increase your blood pressures. But the issue about this drug is that physiologically, when you increase the systemic vascular resistance, okay, it causes a reflex bradycardia. All agents that do that cause a reflex bradycardia. So it's a typical opposite of that. Amlodipine, nifedipine, they are vasodilators. Please do you all know that they cause peripheral vasodilation. So you shouldn't be surprised when someone on amlodipine or nifedipine tells you that because they will cause a reflex tachycardia. Please you all understand that. Okay. So for a patient who is bradycardic, I wouldn't prepare phenylephrine or as a push-dose vasopressor. No, I'd rather use noradrenaline because it has epinephrine because it has beta-1 effect. Okay, so Mrs. Forson has been intubated. The drop has been stabilized. She is on NORAD now. We think you're going to run NORAD for a while. Would we want to use a central line, continue using a central line, or we would want to use a peripheral line? Remember, she came from the ER, so most likely, maybe she still has the peripheral line in situ, right? So what do we want to do? You know, some of the nurses will say, "If I no want to central line, maybe we should know." Do we do that? Oh, okay. I've heard that before. Okay, place a central line for consider administration to peripheral line. Okay, all right. Now, I'll make this simple. Administering vasopressors to peripheral lines are safe. Are safe if you do it properly. There is nothing wrong with administering them to peripheral lines. The reason being that, you see, when you do that, when a patient is in shock, and not now come to prep and pass a central line, the person has a peripheral line. Just start it. When you do that, you're able to attain a MAP quicker, get a patient out of your hands as soon as possible. Okay. Also, there are some advantages of using central line. Yes. The person is coming to the ICU, you'll be running NORAD, infusions, drugs, blah, blah, blah. So you probably would want a central line so that you'd run lots of medications through the central line, isn't it? But what we should know is that not having a central line shouldn't delay the administration of a vasopressor. Never. You just need to know how to run the medication through the peripheral line. Are you okay? Okay, so which is a preferred peripheral IV access for a vasopressor administration? Most of us set lines, right? Where do we set it? You have seen someone there. Here. So where should we set it? Oh, no response. 50-50. So that's our answer. But we had to 50-50. Okay. So, like I said, there's nothing wrong with setting it through a peripheral IV. Where we should actually set it is proximal to the antecubital fossa, not distal. Why? Because all we need to make sure is that the line is in a large vein. Okay. So not on the wrist, not on the hands, not on the feet. No. Proximal to the antecubital fossa. So what's a good peripheral IV? How many of us set lines using ultrasound guidance? We can use our eyes. We can use our eyes to see the vein, so we don't need it. Okay. So actually, the size of the vessel should be more than 4 millimeters. If you use ultrasound guidance, you would know, right? And then the catheter you're using shouldn't take up 50% of. It should take up to 50% or less of the size of the vessel. Why? Because you don't want, if it's more than that, it can easily clog and thrombose. You don't want to do that, right? And then the IV that you're using should be either 18 or 20 gauge catheter. You don't use 23, 24, no. 18 gauge, which can draw and also flash. So when you don't do this, this is what happens. Ischemia. So you can have patients losing their gates, right, going for amputations and the like. That's what you want to avoid. This is extravasation. Okay. So what happens is that they are vasoconstrictors. So when they go out of the vessel, all the tiny capillaries will just constrict all of them and reduce into that particular limb. Okay. So what do you do? What will you do when there is tissue extravasation? There is a drug we can use. It's called phentolamine. Phentolamine is an alpha adrenergic antagonist. So it reverses the vasoconstriction that your vasopressor done. Okay, if it comes as 5 and 10, you just dilute it in 10 to 50 ml saline, and then you just push it into the line. But I'll show you how we will do that very soon. So some call it the MAC protocol. Some you call it the MAC protocol. So when you have a patient who has some extravasation, what you do first is stop the vasopressor infusion. But don't take out the catheter. Leave it there. All you're going to do is take a syringe and aspirate whatever was in the catheter. Okay? Just aspirate it. Sometimes it can make it worse, but don't worry about that. Still aspirate whatever you can aspirate from. So you aspirate there. With the catheter still in place, you just prepare the phentolamine. Some mix it with heparin. You can run heparin together too. So you just inject the phentolamine directly into the catheter. Okay, he's saying there. Then slowly draw back the catheter. So as you are drawing, you're injecting so that it fills the area in which the extravasation occurred. Okay. Now, what you do is that after you do that, what some people do is when they take out the catheter, see the prick, where the prick is, that is not where the tip of the catheter was, true or false. So they'll just place the catheter there, the entry point at where the tip is, to just tell where the tip of the catheter was. When you get the tip of the catheter, then you just inject the phentolamine, like you can use a clock, at like 12, 6, 9, 3. So you just inject it around it. And after that, you do what? You mark the area. So you're just supposed to just take a marker, just mark the area. Why do you need to mark the area? Because you're expecting to see something. There should be like hyperamic changes. There should be blood flow to that area. You're supposed to do this within 12 hours. Okay, so once you see that, you do that as quickly as possible. And from time to time, you also assess. So that if he did it and then went home, next shift, so you also continue monitoring that particular area. Okay. All right, so from a pharmacological view, which of these drugs do you think can easily cause, less likely to cause extravasation? That is tricky. I think that is enough. Okay, let me try and answer that. Okay. So the answer is ephedrine. Let me ask, how many patients have, or do you know, have complained of like limb ischemia or have gone for amputation, patients who use EpiPens? How many of them have like extravasation? Have you ever heard of it before? The EpiPen subcut that we use, right? And the subcut is actually 1 milligram. It's 1 in 1,000 dilution. Do we all agree? Why? Actually, look at how adrenaline acts on both alpha and beta. But like I said, it has beta effect, more beta effect. Beta 1, beta 2. Beta 2 causes what? Vasodilation. So from the pharmacology, the receptor activity, it doesn't really cause that vasoconstriction that you expect it to cause. Please, do you all understand that? Okay. Compared to dopamine, no. Phenylephrine is a pure alpha agonist, so it will just constrict. When you have extravasates, that will cause limb ischemia. Same for vasopressin. Now, I think I almost gave an answer. Which of the following would you avoid administering through a peripheral IV? This one is also tricky. Eh? Let's just have one person answer and let's see. So most of us agree with dobutamine, right? Right? Okay. No, it's not dobutamine. It's vasopressin. Do you know why? You have an antidote for catecholamine extravasation. Vasopressin is a non-catecholamine. It doesn't work on alpha receptors. It works on V1 receptors. Pentolamine works on alpha receptors. So when vasopressin extravasates, you can't do anything. All you can do is take a catheter out, aspirate, place a warm or cold compress, elevate the arm. You can't reverse it. Please, okay? So we don't never put vasopressin through a peripheral IV. No. We're all okay. Please, do you all understand what you're doing? Okay. All right. So I would want us to take a short break. If anyone is confused, is anyone confused? Please, I hope what you are doing is helpful. Okay, great. I also mentioned that you'd want to consider using steroids. Please, do you normally use steroids? Do you add the steroids to the vasopressors? Yes. When a patient is like in shock, septic shock in particular, and you are doing NOAD, or you keep doing NOAD. That's all. Okay. So it's a little veering off the topic, but I added this because the steroids actually affect vasopressors. So what the steroids do is that they sort of increase their transcription, just like the production of adrenergic receptors, so that the vasopressor you're giving can work on the receptor and give you the effect that you want. Please, are we okay? Okay. The other thing is that it also helps the interaction between the catecholamine and the receptor itself. So when we add corticosteroids to the vasopressor and you are running, you realize that we have a better response than not adding the steroids to the vasopressor. Now, we still can't attain pressure goals. We've added hydrocortisone and fluorocortisone. The blood pressures still drop. She's still on NOAD and vasopressin. Now she's less responsive and her urine output has decreased. Why are we still seeing this? I want to take your mind to your patient. Remember I said, when you increase the infusion rate, you assess, you check your goal, you assess, you increase, remember, right? But if you're not seeing what you're supposed to be saying, then it means something is wrong, right? What are the possible things? Anaphylaxis to medications. How many of us see a patient reacting to a medication, especially a patient who has been sedated and intubated? Patient. Another thing is metabolic acidosis. And most of our septic patients are acidotic. And let me say, if your patient is acidotic and you're running a vasopressor, it's running not at 10 million. What acidosis does is it makes the vessels lose their elasticity, very flaccid. So the vasopressor you're giving will not respond. You won't do anything. So what you're supposed to do is to correct the acidosis. Either you run BiCAP, okay, or consider renal replacement therapy, or in fact, what some of the intensivists will do is just increase the minute ventilation on the on a ventilator. Yes, so to blow out the CO2 that's been accumulated. But one thing, if you are running bicarbonate for such a patient, please look for a different line and run your bicarbonate. Never run bicarbonate in the same line as your vasopressor. Why? Bicarbonate is an alkaline solution. Alkaline solution will inactivate all your vasopressors. Please let's take note of that. Other thing, you're treating an infection, and some of the infection might create abscesses. And for antibiotic, where there's an abscess and you're using the antibiotic will not work because it can't penetrate, okay, on the abscess. And cardiogenic shock. So for a patient who just comes and then you started no adrenaline, you're doing it, and it's not working, probably you may never know. Maybe the person has some underlying pathology. Something like maybe the person has left ventricular hypertrophy or some silent MIB somewhere. Okay, and once you are running it, realize that, like I mentioned, output becomes very difficult because you keep increasing systemic vascular resistance. Okay, and patients with septic shock can actually have what we call sepsis-induced cardiomyopathy, where the sepsis in itself affects cardiac output, pumping, the squeezing of the left ventricle. It actually affects it. Okay. Then vasoplegia. Sometimes all you can do is you administer your medications. It won't work. Why? Because the vessels are just tired. So EPOCUS reviews the absence of stress-induced cardiomyopathy, but we think the person has a perinephric fluid. That's an abscess. The heart rate is 110, BP is 90 on 35, pH is 7.3, and then central venous oxygen saturation is 60. What should be your best course of action? So either we increase our vasopressin dose, continue it at the same rate, add a third vasopressor, or consider nitric oxide, Avenger. Now, let me tell you way ahead. There are new therapies that are coming up, okay? Our motto is innovation, network. The theme is advancement, right? So there are new, in fact, probably it's not here. I don't think anyone from UGMC. Okay, please, do we have methylene blue? We have hydroxycobalamin in methylene blue in Ghana, but I've not seen anyone use it. It's like more of like an off-label use. So we have, because I said nitric oxide scavenger. Okay, so let's see what it is. Okay, so we should add a third vasopressor. So we can consider adding a third vasopressor, and at this point, maybe the vasopressor you'd want to add is something with some inotropic effect, because all you've been doing is trying to increase systemic vascular resistance, but nothing is happening, right? So you might want to consider something with inotropic properties, like dobutamine, dopamine, or ephedrine, adrenaline. Sorry, epinephrine, that is adrenaline. Okay, right. Now, we would want to be a little bit careful about which agent we choose. Dopamine has actually now been, it's like more or less facing off. How many of us still use dopamine? Please be careful about dopamine. What dopamine does is, the dopamine's mechanism, okay, of action, it works on alpha, it works on dopaminergic receptors, it works on beta, but all these things are dose dependent. If I want to target renal vessels, there's a particular dose I would use, 0.5 to 2 micrograms per kilogram per minute. You can cross-check. Some of them they vary. If I want to target alpha, the last one is the alpha effect. Alpha effects are at high doses, above 10. Okay, in between, then you have the beta effect, the beta 1 effects. So if I want to improve renal blood flow and I want to use dopamine, I'll use it at a low dose range. If I want the beta 1 effect, improve cardiac output, I'll use the one in between. If I want alpha effect, I'll use the one up there. How many of our cardiac monitors can measure pulmonary capillary wedge pressures? Okay, all right. It's more of like facing, not like facing, it's still there that people you use. It's because it has a lot of issues. Because of the alpha 1 effect, you see, when you're using a dose range that gives you the beta effect, you can't tell if it is beta or alpha. Like I said, the renal one would give you vasodilation, improved urine output. The beta one will increase cardiac output. But when you're using it, there's a thin line between getting beta 1 and alpha 1. So what would happen is that in as much as it's squeezing the heart to pump out, it's also increasing systemic vascular resistance. And when that happens, when you increase it a lot, it makes the heart very irritable. So when you're using dopamine, you realize the person has a lot of tachycardia. When you are using dopamine and you see tachycardia, please stop. Please, let's take note of that. If you're using dopamine and you see tachycardia, stop. Because it's caused myocardial ischemia, and the person can easily arrest. Most often, they'll go into ventricular tachy when you use dopamine. Okay. That's why a lot of people don't like using dopamine. And that's why patients with cardiogenic shock realize that they like using dobutamine more than dopamine. Why? Because dobutamine has that weak beta 2 effect that will dilate the vessels for you, so it will reduce the afterload. So it will make it easier for the inotropy to occur. Okay. I think we've talked about adrenaline, so I'll just skip. Okay, I asked if there's anyone in anesthesia here. No one. You just let me just still say it because it's knowledge. So, if you have a patient who is being put on a table, anesthesia meds, you have the halogenated anesthesia med, isoflurane, desflurane, and they give, most likely if the person has gone to theater and has been given that, okay, and then comes, and you're supposed to give ephedrine, please be careful. If you use ephedrine in a patient who has been given isoflurane, enflurane, desflurane, they are all halogenated, okay? What will happen is the person will go into a VFib. Yeah, so they know, most of them, almost all of them know, because they're actually normally taught, so they don't normally use halogenated. If they use it, they know that they are not supposed to use ephedrine. Epinephrine. Okay. So the vasodilator scavengers, we all chose them. So I suppose we all know them because a lot of us chose them. So like I said, these are new molecules, and what they do is that, let me use an analogy. How many of us drive? More than 50 of us drive. 50% of us drive, right? Okay. So in septic shock, we said there are a lot of vasodilatory mediators, right? Nitric oxide, cytokines, and all that. And that's what is reducing your systemic vascular resistance. And you're putting in a vasopressor to sort of cause constriction. So you stepping on the accelerator, I'm using this analogy. It's more like you increasing the systemic vascular resistance. Whilst you are stepping on the accelerator, you are still stepping on the brakes. The brakes are the vasodilatory mediators. So all we've been doing is that we've been stepping on the accelerator and at the same time stepping on the brake. Please, you understand? Because those vasodilatory mediators are still there. Please, you all get it? Okay, so what these medications actually do is that they are scavengers. They scavenge nitric oxide and hydrogen sulfide. Okay. Hydrogen cobalamin scavenges these two, and methylene blue just scavenges this one, nitric oxide. So what they are supposed to do is that when you administer them, they are just going to mop up nitric oxide and hydrogen sulfide. So that if you are mopping it up, then it means that it is taking your foot off the brake. Can you all imagine that? So that the little vasopressor you use, the little force on the accelerator, it will move faster. So you can increase the systemic vascular resistance faster. Please, do you all get that? Please, do we all get that? Okay. Or we are tired? Okay, so that's what these agents do. They just scavenge, mop up nitric oxide and hydrogen sulfide. But like I said, they are actually common. Hydrogen cobalamin is just like a precursor for vitamin B. It's used for cyanide poisoning. Used for cyanide poisoning. This one is for methemoglobinemia. This particular one. Okay. So the only issues about this medication is that methylene blue, for one, when you administer it, it will color the patient's urine green and blue, like greenish blue in that wavelength. Okay, that's what it does. And then hydroxy cobalamin will give you like a burgundy red coloration. Therefore, methylene blue, patients who have G6PD can't use this because this causes hemolysis. And patients who are on SSRIs, selective serotonin reuptake inhibitors, monoamine, you can't do that because you can also give them this because it causes serotonin syndrome. So they can't really use this. But most of the trials that are being done advocate for this particular one, methylene blue over hydroxycobalamin. But most of them use any of them if you have it. Now, for hydroxycobalamin, how many of us accompany our patients to the dialysis unit for the CRRT? Okay, how many of us have a dialysis machine in the ICU with us? Okay. Have we seen this before? Have you seen it before? Okay. So what hydroxy? It's actually a blood leak sensor. It's like a detector. So what it's supposed to do is that it's supposed to beep or make an alarm when blood leaks into the dialysate. I mean, you can't imagine a patient going for dialysis or so that's what it's supposed to do. So what happens is that when you give hydroxycobalamin, because it stains, I mean, not stains, but it causes your urine to be burgundy red, it gives a false indication for the detection. The alarm will be just blowing and then stop the renal replacement therapy. So if you give it to a patient, it means the patient can't go for dialysis. And the half-lives of these medications are very long, 24 to like 30 hours. So you have to wait till everything washes out before you can take the patient to dialysis. But they are very good, and then they are normally used at the tail end. So if you are going to add like a third agent, a third vasopressor, then you might be thinking about this. So I'm mentioning this because we can be advocates. Wherever we work, we can tell if there is a pharmacist that you work with so that they can take it to DTC because it actually helps patients a lot. Okay. Okay, so back to Mrs. Forsen. We're almost there. So she's been given all those medications. She's awake. She has been extubated. I mean, she's on low dose, not hard now. But when she gets out of bed, she feels dizzy, and she has to be put back on the vasopressor. But what we want to do is to get her off. What you want to do is to get her off vasopressor. Now, what I'm trying to say is that how do we wean a patient off the vasopressor? And this is it's very personal for me because most of us work in the ICUs, but I believe some of us, because of our more or less like rotations, some of us might end up on the ward. And on the ward, what I normally see is patients in shock. You set up no adrenaline, and then we just leave the patient on the no adrenaline. The same rate. Oh, it's very practical. It happens. So how do we wean a patient off a vasopressor? Now, remember we've added noradrenaline, you have noradrenaline, vasopressin, and the others, right? So the person is on 2 vasopressors. How do you wean the patient off? Noradrenaline and vasopressin. How do you wean the patient off? Which one do you start first? Or you stop the 2? So 50-50. Titrate vasopressors up to compensate for drops in blood pressure. Gradually wean off vasopressors, beginning with vasopressin. It says consider initiating midodrine. We'll talk about it. How many of us have heard of midodrine? No one. Not really common. Okay, so how do we wean a patient off? Remember that when we were starting, we set a goal, right? An MAP goal. We also said we wanted to see certain things like urine output and blah, blah, blah happening, right? So how do we now wean the patient off? Now, we want to get the patient off the vasopressor quickly. Okay. For her, remember we said she has chronic hypertension. Now, for some patients, if you want to get them off a vasopressor quickly, and they can be mobile, you can mobilize them, get them out of bed very quickly. Just get them out of bed. If they feel dizzy and all that, you can just put them out of bed. But the quickest way to get a person off a vasopressor is to make sure the person is mobile, right? Okay. What we can do is maybe the target, we say 65, isn't it? Above 65. Maybe let's move the target to between 60 and 65. Remember, I said, in as much as we are looking at figures, let's also look at the patient. She's alert, she's awake, she's doing fine. Why should I still keep my target as 70? She's recording a map of like 60, 61 or so, and she's doing fine. So maybe we can just move our target a little bit down and see if she will be stable on that. So that's moving a goalpost. The correct way to wean the vasopressor is also to wean the patient off the catechol amine vasopressor first. So if you have a patient on NORAD and vasopressin, please wean the patient off the noradrenaline first. And how do you do it? You just titrate down every 1 to 15 minutes. That's how you also do it. Sorry. It's every hour. 0.1 micrograms per kilogram per minute. Every hour. You just wean the patient every hour. And the every hour cuts across for almost all the vasopressors. Okay. And maybe we should also be thinking why she's still dizzy when she gets out of bed. Why is she hypotensive? Now I'm saying this because often as physicians, nurses, health professionals, in as much as we want to treat a patient holistically, we tend to forget certain things. A patient comes to the ICU with chronic hypertension. If the patient is doing well, everything is fine, okay? Maybe you've treated a septic shock, and the patient is going to go home. Would you initiate the antihypertensive medications? What I'm trying to drive at is we often tend to forget about some comorbidities a patient has. So, for example, a patient with adrenal insufficiency or who is hypothyroid, okay, or is on levothyroxine, okay, and the person keeps going to hypotension, will most often not initiate the levothyroxine until the patient goes some cry. So we should always go back and look at comorbidities the patient has and use it to explain why the patient is presenting like that. Then the last thing is midodrine. Midodrine is a selective alpha adrenergic agonist. But it's just like a vasopressor, isn't it? So what it can do is that, but it is oral. You can give it oral. What it can do is just still keep increasing the systemic vascular resistance and maintaining the mean arterial pressure. So you don't need, put in the lines being in there. The patient can just swallow it. And it also means that the IVs can be taken out as soon as possible. The person still has a catheter in there, catheter side complications, infections, and all that. And in as much as we bring the patient off the vasopressor, as soon as possible, the person can be able to go home as soon as possible. For early patients, a day in the ICU, okay, they would need a week. If they go out of the ICU, they need about a week to come back to how they were again. So the sooner, the better. Reduce length of stay. Please, are we all okay? So we can give midodrine at 10. Again, we can suggest it. It's not common. It is in Ghana. Midodrine is in Ghana. It's like 20-something cedis for a tablet. It comes at 5 milligrams and 10 milligrams. So we can use midodrine. Mrs. Forson started on midodrine every 8 hours to facilitate the weaning of the noradrenaline. She's well. She can do physio. She's left the ICU. We call back to check. She's doing fine, and she's back to her baseline, and she's off the midodrine. Another thing about midodrine is because it increases blood pressures. Remember, this patient is hypertensive, so you don't want to leave her on midodrine. That brings me to any oral medication that you give to a patient in the ICU that was for a particular pathology, a condition, right? If the prescription was for 5 to 7 days, and maybe on the 5th day, 7 days, and on 5th day, the person was transed out, normally they'll go to the ward. From the ward, they'll go home. I don't know how many of us do follow-ups, but you realize that most often, these patients end up taking the medication home and continue. Meanwhile, they are not supposed to be continuing the medication at home. Okay? Please, let's also take note of that. That brings me almost to the end of my presentation. This is just about how to care for, how to store the vasopressors. Most of them are not supposed to be refrigerated. You store them at controlled room temperature. Controlled room temperature. The temperature is always 25. It should always be 25. If it says stores at 2 to 8, it's always 2 to 8. You don't take it to 30 and bring it to 25 and take it to 8. No, don't do that, okay? And I think that'll be it. So what I want to say is that understanding the vasopressors, the receptor physiology, the pharmacology behind it, will just simply help us to know when to start what, when to choose what, and even how to give what and how to add what to another vasopressor. So thank you very much. This brings me to the end of my presentation. This one.
Thank you very much, Dr. Kumi. There's Dr. Nicholas. There's Nicholas. Thank you, Nicholas. We really appreciate. This has been very insightful. It says for all inotropes and vasopressors, remember to dilute with a dextrose-containing fluid. We open room for questions, additions. The chairperson will set the ball.
Very much, Madam Moderator. So, Nicholas, thank you very much for this very insightful presentation. So for most of us are working in the clinical areas, and it's a refresher course for us, and it's going to improve on our practice and improve the outcome of our patients. Please, I have a question on, I'm not too sure which particular slide, the settings on the ventilator, just to push out the excess CO2. And you also start your bicarb perfusion. Usually the patient in the ICU, they have a double lumen or a triple lumen, and now there's even quad lumen. So you mentioned something that struck me. You shouldn't, if there's a vasopressor running, right, shouldn't combine the bicarb. So in our context, where you want to reduce infection, so you are just using the central line. You have designated ports. So if you are using that, the medial, the distal, or the proximal, would there still be an interaction?
Issue. There will be no issue. Yes, there will be no issue. You see, the thing is, all of them, we don't want the drugs to, if it is in serum, it's different from when it is in the line. Okay. The issue is that when I have, maybe I'm using a two-way tap, and I'm running the bicarb in one, and then let's say, not add in the other. That is the issue. I don't know if you can all visualize that. When they come together before they go, you don't want that to happen. Yes, yes.
On the ward, I think that is where I see the problem. But there have been instances that they bring patients to the ICU. Even Celipid, they don't use the central line. And sometimes they run this vasopressor before they bring the patient down. And there are a lot of extravasations. I mean, they get those erythemia and Please, are you going to leave your slides with us? Yes.
So actually, most of the slides have notes.
Yes.
Okay, notes in there, so you can read those notes.
So we'll find a way of putting up a protocol for our colleagues on the ward. Thank you very much.
It's unfortunate I'm also Kumi, but you don't want to be called Kumi. Yes. Okay. So I want to find out, is there any modality in terms of inotropes and then the vasopressin administration? Because if I realize what you said, like they start with the, let's say the inotropes that we know, and then they come in with the vasopressin. Then you've now enlightened us by saying that we can add steroids to it to make it more potent. So is it something that is fixed, or an intensivist can adapt its own way of managing its cases like this on the ward?
So the protocol for septic shock is to start with almost all forms of shock, except hemorrhagic shock, because you need is blood. Okay, so what you start with, the common one is to use noradrenaline. That's most often the best choice. But the differentials come when, depending on the pathology. So for septic shock, the protocol per surviving sepsis guideline is to go for vasopressin. If you don't have vasopressin, you can use adrenaline. Okay, if you don't have vasopressin, doesn't mean you can use adrenaline. But the protocol is your second option should be vasopressin, because, like I mentioned, vasopressin has certain benefits because it works in two ways. Someone with septic shock has low, and most of these protocols are from studies. So we realize that most of these slides have studies in them. But if you don't have vasopressin, you can do adrenaline. You can decide to do, in fact, some even decide to do dobutamine. So what they'll do using dobutamine will be to increase the inotropy. As you increase inotropy, will increase cardiac output. As you're giving the NORAD, that will increase the systemic vascular resistance. So CO times TPR increase your MEP. Yeah. Okay, understanding how all of them would work helps you with what you choose. So if I'm at a point where I realize that my output is low, I might want to use an inotrope. Okay, there are certain patients when you start using inotropes, even in fact things actually get worse. That one it's maybe another time I can mention it. So it's not record, but the protocol is already there. Do noradrenaline, but then the next step is vasopressin. If you don't have vasopressin, you can consider ephedrine, epinephrine.
Okay, so the follow-up is that is there any clear cut for the milligrams of noradrenaline you can hit? Because I've seen intensivists going as high as quadruple strength of NOAD by titrates. So is there any clear lines to that?
Actually, there is no maximum dose. There's no maximum dose. But like I mentioned, law of diminishing returns. As you keep increasing the systemic vascular resistance, at a point, it will not help you. So the main thing is, like I said, as you keep increasing it, look at the patient. Because there will be a point where you keep increasing it and actually things would actually just get worse for you. Okay.
Last one.
It's adrenaline. So it depends on, you see, you can't, the doses for about vasopressin is the person should have a central line.
Thank you very much.
Supposed to do the dilution. So for instance, for adrenaline, like I said, if you're going to use as a push dose, so if an intensivist says that I'm going to do RSI, prepare, let's say, adrenaline, not because the patient is coding, but you think the patient will code, so you will do 1 in 10 dilution, right? But you're not going to use that 1 in 10 dilution as a push dose. You're supposed to further dilute 1 ml of the 1 in 10,000 in 10, up to 10 mils. You don't push half of the 1 in 10,000 as a push dose to prop up the blood pressures. That's why I said, if you do that, the pressures will just shoot up. Yes. Yes, you know, I don't know if anyone has seen it before. I've personally done it before. I almost regretted doing it. I think we've diluted it.
Then what we are doing, some of us, is not best practice.
Yes.
Because we do the 1 in, when there's a code, we don't have the pre-filled packs, so we do 1 in 10,000. However, in the process of resuscitation, We give raw adrenaline, 1 milligram.
No,
Raw adrenaline, not diluted. Then we flash with normal saline. Am I right or wrong?
Hey, so I asked you, you all said, I asked you if you do that. You all said, oh, no.
Nicholas, please let's clear the air. When the patient codes, we do the 1 in 10,000.
Okay.
That one is there, we label.
Okay.
However, in the process of resuscitation, we give raw adrenaline.
Please,
1 milligram.
how many of us have gone through BLS, ACLS?
Yes.
You realize that they write it in the dilution, the 1 in 10,000. The 1 in 10,000 dilution is 1 milligram of noradrenaline in 10 mils. That's it. The normal adrenaline that you use is 1 milligram in 1 mil. So you take 1, dilute it to 10. So just draw. This one is just coding. So saline, dextrose, whatever. Just put.
Yeah, so the issue is we give 1 milligram bolus and the adrenaline, and then we monitor 3 to 5 minutes. We repeat.
Yeah.
So so it's a bit dicey in the sense of having the 1 milligram in 10.
You see,
which
the reason why most of us don't pay attention is that the patient has coded, isn't it? So you realize that people don't take it seriously. But the clear protocol is that use 1 in 10,000. And the reason why they use 1 in 10,000 is because they have the EpiPen, that's dilution there. We don't have that. So if you are going to use that, it means that we have to dilute it. But because the person has arrested, if I push the 1 milligram and I follow up with saline, you will not see anything. You're still doing CPR. Right? But that is also wrong. That's not the ideal thing you're supposed to do.
In fact, I've had issue with some students before. Yes.
Please, I think we'll take 2 more. Last 2.
Hello. Thank you, doctor. Please, are we together? I have been out of the ICU for some years now. And I'm just looking at the scene or the scenario outside the ICU. And some of the cases you presented just mimic what I've been seeing. And the kind of treatment that we give. Sometimes I'm in the hospital. So the cases that come from the CHIP compound, the health centers to the hospital, and by the time they arrive at the hospital, they are half dead. Can we, colleagues, leverage this to make ourselves visible with the network of practice? Because a lot of things are happening. Sometimes I feel so sad. We have our relatives outside there. We are confined to the ICU. In case your mother lives somewhere and something happens, where is the first point of call? Sometimes it's at the CHIP compound, it's at the health center, it's at the hospital. Who is at the hospital? What can we do? Thank you.
Thank you. So I wanted you to go back to that slide of the adrenaline reconstitution. I just want to snap it and send it fast before another thing happens on my ward.
So normally what I it's because of time. For critical care, what I normally say is that most of the things in critical care is simply understanding pharmacology and physiology. If you understand pharmacology very well, you do very good. So what I normally start with is to be a little bit elaborate on the pharmacology behind the vasopressors and stuff before I start talking about the nursing issues, but we don't have time. But if you may, Mrs. Yosen, if you may, we can schedule a Zoom something, then I'll just do, you can speak to, so we can speak to Madam Rita and Mr. Danny so that you can do that. Please, someone had a question.
Yes, please. Okay. Okay, thank you very much. Please, my question is that is it all the vasopressors that have to be diluted with the dextrose containing fluids, or only noradrenaline?
All vasopressors.
All of them. Thank you.
Thank you very much.
Please, this one is in the context of using it as a push dose. Okay, so if I want to run it like an infusion, I'm not going to do it like this. You can dilute it. Most of them are in 250, in 500, in 1 liter. So you can put 1 in 250, 1 in 500, 4 in 250, 4 in 500. What's important is the concentration that you get. Please, are we okay? This particular, what you are taking, isn't it adrenaline? Oh, don't worry, I'll send the slides. Okay. This is adrenaline. This is only one on adrenaline.
Okay, so my question. So you made mention of the fact that most of the times when we give the Ringer's lactate and we take maybe a blood sample, we see that the lactate is very high. So, and sometimes we are very alarmed and start correction or start treatment. So I want to ask that in this case, maybe even if the central line has maybe triple lumen or double lumen, they all end up in the openings are different, but they all end up in the same vessel. And you take the sample likely around the same place and you may still get. So do you have to use a different line for the Ringer's, or you can?
So the issue is taking the sample from the same line you run the Ringer's lactate from. If you are running the Ringer's lactate from in one line, most of it will designate one line for sample, taking samples. So you don't need to run anything through that particular line. So nothing will happen.
Dr. Nicholas, I've worked in a hospital that used so they know they come in bags. Here, I'm yet to see some. So there's no ambiguity when it comes to the nitrate or whatever your terms. So they come in like 250 bag, like no add infusion. So when there's a code and you want to increase the map, this is what you are going to use. So I don't know whether there's a plan of getting those bags for us in the country.
So what I normally, so fortunately, I'm on, how should I say it? So what if there is a need? So for most institutions, right, almost all tertiary institutions have, no, in fact, all institutions have DTCs, Drug Therapeutics Committee, okay? And then every institution is supposed to have an internal formulary, which you get from like an essential medicine list from the whole Ghana, but you're supposed to get your own formulary. So there are certain medications that I'll be using that you'll probably not be using because you probably don't have a specialist who needs or requires that particular medication. So what they need to see is that there is a need for a particular medication, then the hospital will get it. So if you want to use 4 in 250, that bag, you need to make sure that you relay that to maybe the DDNS, whoever is on DTC. They sit on it, they talk about it, and then now procure that particular medication. You can't just be there and then be looking, or else you might have to look for a pharmacy somewhere that has those bags. But you don't normally get those bags in pharmacies. It's normally in hospital pharmacies. That's where you get those bags, because you can't walk into a farm, they can't store it properly. So you're not getting like 4 in 250 bag. No, you have to get it in a hospital pharmacy. So you normally store it in a hospital pharmacy, not the other chain pharmacies.
My last question, please. The dopamine, the bone of contention between dopamine and NORAD. I also worked in a facility that they tell you, I asked why they are so conversant or they use dopamine a lot. And the response was that, dopamine is cardioprotective. But today, it's rather the reverse. I mean, listening to you. And these are doctors and intensivists, and it's like, they love dopamine. And that is what they have been using You ask and they say that it's cardioprotective, it's cardioprotective, it's cardioprotective. So what are they doing to their patients?
You see, if you can keep an eye on what you are doing, personally, I don't have any issue. So if I'm running dopamine, and then, you are doing invasive monitoring, so you can see CVP, PCWP, you can see all those figures, okay? And then that actually is what guides the intensivists as to what they are doing. If CVP is low, they know that fluid status is low. So maybe let's give the person fluids, okay? If they see that PCWP is sort of high or low, they know what agent to do. So for example, dopamine actually increases pulmonary pressures. So we realize that a patient with cardiogenic or in heart failure who has gone into cardiogenic shock, they don't normally use dopamine, because if you use dopamine, one thing to do is that to make it very difficult for the heart to pump blood out, because it constricts, although it has inotropic properties, it will still constrict the aorta and increase systemic vascular resistance, but also constrict pulmonary vessels. And then the pulmonary blood vessels, most often they are capillaries. When you do that, you easily cause fluid to leak out. It's mechanics. When blood is flowing through a vessel that is really constricted, hydrostatic force is greater, so it will push fluid out. So if you do it in a patient who has heart failure, who is in shock, you complicate the pulmonary edema, so they don't do well. So you realize that most often they will do dobutamine rather than doing dopamine. If you can monitor what you are doing, fine. But what you should know is that dopamine can cause A, B, and C. So when you're using it, look out for it.
Thank you very, very much, Dr. Nicholas.